Hello, this is part 2 of a two-part video series on tissue contaminants in the pathology lab. Part 1 provided an introduction to tissue contaminants and the steps of tissue handling in the pathology lab. Now that we have gone through the workflow and identified the high-risk steps, let's talk about how to troubleshoot tissue contaminants in the event that one is present. The authors provided this table that summarizes the different considerations when investigating cross-contaminants, and we will dissect these issues in the next segment. First, to decide if a contaminant is present, the main things to consider include: what is the clinical indication, does the contaminant belong, and if there are any other additional clues or ancillary testing that can confirm the presence of a contaminant. We will go through them one by one. Knowing the clinical indication and impression and what should or should not be present is important. This case study illustrates the point. The case was a breast core biopsy specimen showing a fibroadenoma and containing a fragment of benign parotid gland tissue on a single slide, seen on higher power in picture B. Given that the contaminant was seen only on one slide, it is easy to assume that the contaminant originated at the water bath stage, and one might make the mistake of not investigating this issue any further. In this particular case, investigations revealed that there was no other parotid gland tissue handled in the lab during the 2 weeks prior to this situation, making contamination at the water bath essentially impossible. Given this, a complete detailed step-by-step review of the in-house workflow was performed, which revealed that the reservoir of the solution used to soak off paraffin wax from reusable molds harbored a number of microscopic tissue fragments, and was the source of contamination in this case. Prior to this, the possibility of contaminant being present in the solution reservoir was never considered. Hence, while benign contaminants may not be diagnostically concerning, they highlight an opportunity to address and identify potential sources of contamination. Here are some helpful clues to decide if something is a contaminant or not. Firstly, contaminants tend to be loosely adherent or far away from the main tissue. The sizes of represented tissue fragments should always be correlated with gross descriptions and specimen photographs where available, and any incongruence should be clarified. When tissue contaminants are present only on one slide or level, they are highly suggestive of a contaminant arising after the embedding step. Always remember to review logs when troubleshooting contaminants. And when all else fails, consider if there are any unique morphological features of the contaminant as a clue. We will further illustrate this point with the next case study. This is a case of a degenerated disc material containing an unusual malignant fragment that was present in multiple sections and a short distance away from the main tissue. Upon closer inspection of this unusual fragment, we see distinct morphological features of anastomosing basaloid cells with peripheral palisading, which is reminiscent of an ameloblastoma. Indeed, this tissue was investigated and found to be a contaminant, which originated from an ameloblastoma resection specimen handled in the same grossing and embedding stations. However, review of the logs showed that the disc specimen was handled first in both stations. So how did this occur? A plausible instance of contamination was postulated to be during transfer between processing and embedding stations, where tumor fragments could have been transferred via gloves or tools onto the disc specimen before embedding was done. So, while we often try to zero in on a particular station when investigating contaminants, this case also demonstrated that contamination can happen anywhere between the stations as well. More clues that can assist one in investigating contaminants include presence of tissue paint, thermal artifacts, or calcifications. For example, if there is a standard procedure in the lab to apply paint on certain core biopsies, the lack of paint in a tissue fragment could be a clue. Likewise, presence of thermal artifacts from procedures not known to involve cautery, or finding calcifications in certain tissues not known to contain them, should also raise alarm. Let's look at how one can apply this in a case scenario. This is a case of a breast core biopsy showing fibroadenoma, but with a cellular fragment in one corner and wedged between fat. This cellular fragment shows a sheet-like proliferation of atypical cells. One may wonder if this could be native tissue, indicating a focal area of DCIS perhaps. However, The keen observer might notice that tissue paint and cautery artifacts are present in this fragment, both of which are not usually seen in a breast core biopsy. The source of the contaminant was later traced to a looped electrosurgical cervical excision specimen with high-grade squamous intraepithelial lesion, where cautery changes and tissue pain are expected. Ancillary testing may be required in some situations to clarify origin of contaminants. Immunohistochemistry is one tool which may help for lineage determination. However, remember that a pitfall exists, as contaminants can arise from the same tissue type. Take a look at this case for example, where a malignant contaminant was found in a benign breast core biopsy. Note that this fragment was again cauterized and unusually crushed. It turned out that this contaminant came directly from an intracranial tumor resection for a metastatic carcinoma of the breast. Immunohistochemistry for lineage determination would not be helpful and even potentially misleading in this scenario. In cases of contamination, the general principle is to limit immunohistochemistry to preserve tissues for more definitive testing such as molecular studies. Here is a short summary of useful molecular methods to consider for workup of a contaminant. The gold standard method involves short tandem repeats (STR) genotyping, which works by mapping out the highly polymorphic microsatellite sequences that are individualistic. However, other methods such as next-generation sequencing, XY chromosome fish or PCR, or allele-specific PCR or qPCR have also been described. The usage of these methods may be limited, as they require prior information on known mutations of the index or contamination case. We now move on to the second paper published from a histology lab at Monash Medical Center in 2012. The team undertook an extensive investigation of its work practices with an agenda to eliminate the presence of tissue contaminants on diagnostic slides. They adopted several practices and then compared the contamination rate before and after the changes were implemented by review of 200 cases. Here are the implemented changes at the grossing and processing station. The team purchased a large number of forceps and an autoclave machine, and the photo on the right shows an example of a tissue fragment that was autoclaved, showing no viable tissue present. They also committed to disposing consumables at the completion of each case. Additionally, they emphasized a clean work surface in the lab at all times and mandated lining of all cassettes with biopsy pads or filter papers. This also required a change in the settings on the processing cycle to accommodate solution carryover due to the increased number of biopsy pads used. At the embedding station, due to workflow requirements, single-use forceps and embedding molds were not feasible. The forceps were placed into a bacticinerator instead. This is a device that sterilizes tools with infrared heat and can complete sterilization process within 5 to 7 seconds. The embedding molds were cleaned with alcohol and histidine and then autoclaved to remove all potential tissue residue. The team also discontinued the use of tissue stompers. Many changes were implemented at the microtomy station. While initial suggestions were logically sound, many of them were not practical for a busy histology lab. The changes implemented include timely vacuuming of wax trimming, staff vigilance in maintaining cleanliness, and surveillance for contaminants and floaters and daily cleaning of water bath, with bleaching done on a weekly basis. The glass slides also remained in their original packaging until required, instead of being placed flat on the bench during sectioning, to prevent unwanted pickup of contaminants from the bench. At the staining station, the most important change was the purchase of a machine which utilizes a single slide staining technology, such as the one seen on the right. This stainer applies a fresh reagent to each patient's slide, eliminating the risk of transfer of tissue between cases during staining. For the study that was conducted, a total of 572 slides were reviewed, comprising 100 cases before the changes were implemented and 100 cases after. The review was performed by 2 screeners who looked out for fragments of tissue that are more than 5 cells in size with a recognizable histology. Red blood cells and single scattered squamous cells were not included. The presence of contaminants were then recorded as being within 3 mm or greater than 3 mm from the diagnostic tissue. Here are some examples of the contaminants observed before the changes were implemented. The first example shows a breast core biopsy with invasive adenocarcinoma, with a fragment of squamous material directly adjacent to the main tissue. This was only present in 1 out of 5 sections, which suggests its origin in the water bath or the stainer. The staining intensity in this contaminant was noticeably darker, and this suggests that the contaminant arose from the staining bath. The second example is from a torted ovary with a simple cyst, showing an epithelial fragment with columnar differentiation. This fragment appears folded and poorly presented, which are clues to suggest that it is a contaminant. Here are some results from the study. The authors found that the incidence rate for contaminants present within 3 mm from the main tissue decreased drastically from 10.6% to 3.8%, while the incidence rate of contaminants greater than 3 mm from the main tissue decreased slightly from 3.9% to 2.75%. Additionally, the authors also noted that the contaminants were noticeably smaller and more recognizable as foreign after the changes were implemented. To conclude, every tissue contaminant and its investigation should be clearly documented and investigated as an important quality assurance step. This allows identification of weak links and allows for timely improvement before a major issue arises. Despite best efforts to investigate and resolve issues, there may be scenarios where the origin or cause of contaminants are unascertained. Additional steps, such as discussion with physician, involvement of patient relations staff, consultation with medical protective agencies, and potential disclosure to the affected patient may be warranted. Knowledge of general tissue handling workflow, people, and tools involved in tissue processing is necessary to troubleshoot contamination incidents. Prevention of tissue contaminants, process improvement, and quality assurance should be a priority for every laboratory. This is the end of the 2-part video series on tissue contaminants in the pathology lab. Thank you.
We would also like to invite you to check out Pathweb, our free online pathology resource. There are more than 1,000 fully labeled interactive virtual pathology specimens such as this one, and many other interactive elements. Registration is free and the link is in the video description. Thank you.